Welcome everybody to this ASMA presentation on addiction and the brain. Our presenter today is Dr. Matthew Stanley. Dr. Stanley serves as the Vice President of the Behavioral Health Clinical Service Line and as Medical Director of the Avera McKinnon Behavioral Health Center, Sioux Falls, South Dakota, and the Avera Marshall Behavioral Health Center in Marshall, Minnesota. Dr. has more than 20 years of experience as a psychiatrist at Avera and is board certified by the American Board of Psychiatry and Neurology and American Board of Addiction Medicine. He is also a distinguished fellow with the American Psychiatric Association. In his presentation today, Dr. Stanley will speak to us about drug addiction and the vulnerability of the human brain. And with that, Dr. Stanley, I'll turn it over to you.
Thanks, Mark. I will tell you right off the bat, we're going to talk about addiction and its impact on the brain, but this could also be subtitled Addiction is a Chronic Medical Disease, and that'll be a little bit of the case I'm making, as you'll see as we go through the slides today. It's kind of the prerequisite drugs on statistics, or I'm sorry, the statistics that tell us this is an important topic. Really nothing that would shock you here. This is $524 billion a year when you add up the cost of illegal drugs, alcohol, and tobacco use. Use alone is $181 billion, and that's in 2004. Imagine with the opioid crisis we've experienced since that time, it's worse yet. But it's capturing our attention in the medical field currently, and that's the number of overdose deaths. But here is the total number of overdose deaths of prescription meds, 2001 to 2013. You might look at this and say, well, maybe we're making some progress. It looks like we're leveling off. Actually, the data now released up to 2016, which didn't, unfortunately, have a nice slide for, indicates it continues to escalate, and that is really frightening everyone. You see from 2001 to 2013, the number of opioid overdose deaths rose more than almost fourfold there. One more slide in that. As you talk about the opioid epidemic, in the literature, it's kind of described as a threefold wave. So we saw the wave of prescription opioids. So that was the first wave, which kind of overtook us throughout the decade up to about 2012 to 2015. The second wave then was the heroin wave, and the most deadly wave is the synthetic opioids, being the fentanyls and carfentanyls getting to certain populations, and that's where you will see the kind of lacunae of deaths that occur where you have multiple overdose within a matter of a few days because fentanyl or carfentanyl has been mixed in with what the user assumes is a usual strength opioid. A remarkable rise in heroin there after about 2008. Said that is would be the folks that are switching their prescription opioids to whatever is the most easily accessed opioid on the market, and unfortunately that's typically heroin. We're also seeing a secondary rise in needle-borne infections such as AIDS. But I really want to talk about the effect on the brain and how we need to be thinking about addiction as another form of chronic medical disease. And here's the beginning of that discussion. It is characterized by compulsive behavior. People continue the abuse of drugs despite the negative consequences and known risk to their health and well-being. And it does cause persistent changes in the brain structure and function, which a number of the following slides are going to illustrate, hopefully fairly well for you. come a long way. Its ability to visualize what occurs in the brain when substances of abuse are used. A couple we're going to touch on here is I want to show some genetic factors and susceptibilities that indicate some of our previous held false assumptions, such as this is based on weak character, or it should be easy for folks to stop using. These, I think, will be dispelled to a large degree by that have shown the activity of the brain in someone who's addicted or prone to addiction. But in a way, we tried to visualize the brain on drugs. New way. What you see here is a human brain at different intervals after an injection of cocaine. The yellow shows the binding radioactive cocaine, or radio-labeled cocaine. But the effect doesn't last terribly long. And it is well that as the cocaine off the total activity of the brain also declines. Another way to, this is the PET scan here, and I like the slide because it compares a known medical disease, a heart disease patient, with someone who has a diseased brain due to cocaine abuse. So the headline here on this slide, as you can see, is addiction like other diseases because it's preventable, treatable. It does change biology, and if it can last a lifetime, and typically has profound effects on health, including causing death. You see a healthy brain on the left, and then you see the reduced activity of the diseased brain of the cocaine abuser. It's compared or contrasted with a healthy heart, which shows a lot of strong metabolism equally distributed throughout the brain, and then the diseased heart, where the metabolism is reduced and unevenly distributed, just like the cocaine individual. What we understand is that addiction is not simply, as I said, someone with weak character, someone who prefers to use substances to more healthy activities. It really is a mixture of biology, in this case a lot of times genetic predisposition, mixed with environment, and in the drugs that changes brain mechanisms and actions and leads to addiction. One of the things that I think it's critical to realize about addiction in general is this is a disease of the young. It's one of the categorize it as a chronic medical disease, which I do. It is one of the few chronic conditions that start in very early adolescence. So you can hear the rate or the percent in each group. First-time dependence, and in tobacco, as you would suspect, it's at about age 16 or 17. Cannabis, interestingly, is even earlier. Alcohol is right in that same age range. So that's probably several takeaways for us. One of those is that we have to work very early with controlling these substances and working on prevention in the very young. You're seeing a lot of these disorders have already done by the age of 15 or 16. We'll take drugs. Well, feel probably the most reason we would identify if we were asked that people use drugs. They like the sensation experiences and they share them. But we'll look at some data here that will also say that many people use it to feel better because they're already suffering from anxiety, fear, depression, hopelessness. And so the concept of self-medication, which I think sometimes be an overused term, I think has relevance when we look at brain disorders, or the number of people who have a psychiatric disorder and engage in addictive substance. Use drugs because they engage the pathways that are built to us to modify behavior. And by the way, if you have not read this the magazine article that is featured here, it's one of the best and most concise, I think, articles on covering the science of addiction. An enjoyable read. A little bit then about what happens in the brain. So we'll start with something we're all pretty familiar with. We have the dopamine in the presynaptic vesicles and the dopamine receptor. Once the is fired, the dopamine is released into the synaptic cleft, and the activity would be that the dopamine lands on a dopamine receptor and the property of the activity. And one of the things I want you to keep in mind here as we look at the next few slides. So, as I think we are programmed to pursue activities that propagate our species or ensure our survival. A lot of that's through the dopamine pathway. The dopamine is the major transmitter of reward. We see two things that increase dopamine, and we'll compare these shortly to the effect that drugs have on dopamine. But you can see that eating, and I know many people overeat and eat for pleasure. And you see why dopamine is a reward or a pleasure neurotransmitter. This is in the shell of the nucleus accumbens. Food increases 100% is the kind of nominal baseline. So you get you go from 100 to 150% with use of food. Tapers off over about 180 minutes. Is a more powerful reward, about a twofold reward. Now let's look at the effect of a drug, and in this case we'll look at cocaine, but most drugs work through the dopamine reward system. So what cocaine does is, like many of our antidepressants and other drugs do, it doesn't directly land on the receptor. It works more so on the reuptake system. Then is you recall the yellow stars there is dopamine in the synaptic cleft. As the dopamine sticks around longer, it continues to hit more receptors and increases the stimulation. In fact, like we see in the second slide up to the right, you recall that when we used food, we got about a 50% bump in dopamine. When we had sex, it was about a 100% twofold increase from 100 to 200. If you look at cocaine, you can see a remarkable increase, much greater than sex, and lasting up to 4 or 5 hours. Although immediate effect probably tapers off over about 90 minutes. Amphetamine and methamphetamine in this area is an incredibly problematic drug. You can see that where sex would bump up the basal rate to about 200%, amphetamine increases the dopamine release to 1,000%. It isn't sustained over a long period of time, but an incredibly powerful drug in terms of dopamine release. Compare that to nicotine. Even nicotine actually has a higher percent of basal release. immediacy than sex does. So, if people have sex to smoke the cigarette afterward, or have the cigarette afterward to further enjoy the sex. But this I guess, particular or that particular graph could be used to argue that either way. And morphine, powerful, but far more prolonged effect, not really as powerful as cocaine or nowhere near the amphetamine, but significant increase in dopamine. We know that drugs of abuse touch on the reward, primarily work on dopamine, but they also impact serotonin, which, as we know, regulates mood and sleep, satiation, etc., and glutamate, which regulates learning and memory. So it isn't just reward pathways that are affected. This is a brief overview of some of the functions that are involved in the dopamine pathways. We already talked about reward or motivation, which you can elicit things of pleasure or euphoria, feeling of motor function, compulsion or perseveration. You can see there that with the pathways, you also get functions in mood, memory processing, sleep, and cognition. We'll look at this a little differently in the next slide. I do another slide that will touch on that a little further. But so over the short term, drugs will impact the reward circuitry, in our sense of pleasure and reward, and even euphoria. But using these drugs over and over has effects, and they can be both in the structure and the function of the brain. Here we have a couple of dendrites. The one on the right was exposed to a stimulant, and this is where amphetamines can actually alter the structure of the neuron. So these are dendrites of dopamine neurons in the nucleus accumbens. You see that the one that was exposed to amphetamine has far more dendritic spines or connections that was exposed to saline. So it's an actual structural impact on the dendrites. And then this set of PET scans, the effect of dopamine receptors. So at the top you have the impact of cocaine. On the left, the PET scan on the left shows the normal control. The PET scan on the right shows the addicted patient. And way from top to bottom, the level activity is shown in the dark orange, almost red, with blue and purple being very little activity, and yellow and green being moderate level. So these are the number of dopamine receptors, D2, which is our most active receptor, most usually used receptor. Cocaine, you can see the downgrading of dopamine receptors. You see the same thing in the methamphetamine, and in fact, it's even more remarkable there. It also occurs in alcohol and certainly in heroin. Stimulation or repeated stimulation of the dopamine receptors. It's the brain trying to adapt to the environment. But as the receptors downgrade, it gets harder to naturally stimulate or create a sense of reward, euphoria. So it feeds into the compulsion to continue to use the drug to try to feel normal, at least. In fact, if you talk to a lot of heroin users, they will that they initially utilize the drug to feel good. They use it now just to feel normal or not to feel bad. So it moved from a joy and euphoria to a sense of just trying to maintain stability or feel normal for a period of time. So that we look at dopamine receptor environment over short term. Now let's look at this. This is at the top. You can see the of a monkey brain in this case, but after a very top row are the different cuts of the normal control. 10 days of repetitive amphetamine fed to this monkey or injected, and then you see how long it takes the brain to begin to recover. So again, you see on the right is the key in regard to brain activity, with red and yellow showing the highest level activities, blue or purple showing very little. There's a dramatic reduction in brain activity after the 10 days of repetitive amphetamine use by this monkey. It doesn't return overnight. At 4 weeks, you can see very little activity, even at 6 months and a year. One slide is yeah, I think that is 1 year, 2 years. It's not adequately identified there at the bottom. But so even if you look at a year, the monkey's brain is just returning to what looks like a normal level of activity. It's a bad news slide. It's just the prolonged effect of repetitive use. Again, it was only 10 days in what was otherwise a drug-naive primate. It took at least a year, if not longer, to fully recover from 10 days of repetitive use. Some impacts. So we talked primarily there about changes in structure and to some degree function, but these are more about the impact on function. And PET scans with normal control and methamphetamine abuser, and its impacts on task and memory task. And what this does is try to correlate that reduction in dopamine transporters. So we're not looking at D2 receptors, we're now looking at the transporters. The reduction in transporters correlates to those the reduction in effectiveness in both motor tasks and memory tasks. Substance abuser has tried to adapt by decreasing dopamine transporters, and the magnitude of the decline has impacted the ability of the brain to function in its motor and memory areas. The greater the decline, greater was the impairment in the memory and motor area. I sectioned the brain a little earlier that did look at both dopamine and serotonin in the brain. Shows a little bit of the actual segments of the brain and what's important in terms of being able to modify behavior. So up there you have the PFCs, the prefrontal cortex, the ACGs, the anterior cingulate gyrus, and those inhibitory control, or kind of your master control, your judgment, if you will. We often refer to the prefrontal cortex, the area of executive functioning. The area of motivation or drive there, primarily identified as the orbitofrontal cortex and the subcolossal cortex. And reward or salience, we're moving a little more into the limbic area here. We have the nucleus accumbens and the ventral pallidum. And then the memory, we have the hippocampus and amygdala. Another area where we look at that. We talked about prefrontal cortex, or that frontal area, being more with the executive functioning, the reward area, the memory area, and then you have other areas of the brain, such as coordination. This is a slide that just talks a little bit more or identifies, as I said earlier, this is addiction is a problem that strikes very early in our brain. In fact, when brains are still developing, 67% of those with addiction identified by age 12 to 17. So it's very early in the lifespan. If you include the young adult, 18 to 25, you got well over 90% there of people that have already treated their illness of life, which is going to be substance use or addiction. Remember, when we talk about the brain and that executive functioning, as long it takes for the brain to actually mature. This is a slide that shows that to some degree. So what we have, a white circle here, this is the younger brain, age 5 to age 20. We're seeing overlay of the development of mature gray matter. See in the white circle, that's the prefrontal cortex, or the area we previously identified as the area of executive function or decision making. And you can see here that is not developed. In fact, it's one of the areas to develop. Even at age 20, that executive functioning area, that judgment area, is not fully developed. Interesting study. This shows a little bit how adult teens actually are wired a little different. We kind of joke about this. I think it's not uncommon, but this brain activity shown with a functional MRI. And this study really looked at was that both of these are actual brains. These are PET scans of functional MRIs of adult and an adolescent. Look at facial expressed emotion, trying to judge what the emotion was. In the adult, the area that lights up is the prefrontal cortex, or the area of reasoning and judgment. In the adolescent, the way they're trying to interpret the facial expression, they're using the amygdala here, or an area that is really associated more with emotion. In some decisions, some of their discernment is based on judgment, not based on reflection, but more on emotion. So we would argue that do process things differently based on the development and the developmental stage of their brain. Correlate to adolescents being when they're exposed to substance. Well, here's a study that shows the use of nicotine in rats that were first exposed as adolescent rats versus rats that were only exposed after they were adults. You can see that both in the number of infusions the adolescent exposed rats seek, the amount that's infused per session, the rats that were exposed as adolescents utilized the substance more frequently and in greater amounts. So it is obviously that the exposure of the adolescent rat did lead it to utilize the drug more often and in greater amounts. said earlier too about why are some people susceptible to addiction. Is it purely about genetics? Is it environment? Is it weak character? Well, an interesting study that looked at individuals' response to methylphenidate, which is actually Ritalin for we're all clinicians, so we probably quickly understood that. But PET scans, they looked at individuals who either had a high number of dopamine receptors or a number of dopamine receptors, and this is determined more so by your genetics. This is something that was so these are drug-naive individuals, but based on the number of dopamine receptors they were blessed through their genetics, it changed their perception of what it was like to take methylphenidate. Surprisingly, those that already had a high number of dopamine receptors, so were already the environment of their brain was already very receptive to any stimulant normally released. They really didn't for the sensation that methylphenidate or Ritalin had on their body. In fact, they rated it, as you can see to the right, as unpleasant. So as the more dopamine receptors the patient or the test subject had, the less likely they were to find it pleasant. If you had fewer dopamine receptors and you were exposed to a stimulant, you're going to say, you know, I liked it. So the idea being that two things I take away from this. One is that we all have different levels of susceptibility to drugs once we're exposed in terms of how we're going to respond to those. I think we have to try to educate our patients that there is differences in genetics. We shouldn't necessarily be judgmental. I've asked geneticists I've known, said when you see someone who has addiction, it's the best response is to say, there, but for the grace of God goes I, because when the drug was ingested and landed in their genetic environment, had maybe less control than you might realize in terms of how the body and their brain responded, leading up to their lifetime of addiction. Genetics is a big contributor, but it's more complicated than that. And the nature of the contribution is quite complex. These kind of different representations of convergent findings from different labs that identified a cluster of 3 different nicotinic receptor subunit genes, smoking quantity, nicotine dependence, and the risk of 2 smoking-related diseases, which were lung cancer and peripheral arterial disease. So the kind of things that were to uncover through the use of genetics also which really leads to the opportunity to develop better interventions. But when we talk about co-occurring disorders, probably one that is most prevalent with substance use are the number of people who have a behavioral health disorder co-morbid with a substance use disorder. On the graph to the left, the most common, the most common conditions associated with drug disorders. So, in other words, when we look at this mania, at least 40% of those with mania are going to have a drug use disorder. It may not be dependence. I would think of mania commonly with abusing, but it can well be dependence. Interesting, or I think one of the things when I first saw this graph that struck me the most was second most prevalent, or the second most common behavioral health disorder, for a drug disorder, was panic disorder, the agoraphobia. So that's anxiety, that fear of going out, fear of being around people, and the triggering that of panic disorder that causes created a very high number of people with substance use disorders. Although it's not identified in this graph, I assume the type of substances they were inducing were not the methamphetamine and cocaine, but the alcohol and benzodiazepines meant to reduce their anxiety or calm them. You see a couple of the chronic mental illnesses, specifically nicotine addiction. If you look at schizophrenia, it's an interesting disorder if you look at it from just a purely neurotransmitter level, but we talk dopamine is the high pleasure reward, and we saw that nicotine or smoking would raise the dopamine level about 250% or greater, or at least on a parallel with sex. So when we treat schizophrenia, we block the D2 receptor. That's how most of our antipsychotics work. I have rarely met patients I'm treating with schizophrenia that don't have a nicotine addiction. Some context to that idea of self-medicating. Patients that we are blocking their normal, in case abnormal, exposure to dopamine, because it causes things like hallucinations, delusions, etc. But they're trying to seek a little bit of that normalizing, I think, of dopamine in their system, and I think that's why they are commonly addicted to nicotine. Looked at the factor or the risk of having a mood disorder and developing a substance use disorder, but the reverse correlation also, and that is that drinkers have a higher risk of developing mental disorders as well. It's harder to correlate, perhaps. And concepts we've been talking about as we looked at these last few slides. We do talk about both utilizing with the intent to self-medicate, maybe trying to reduce or resolve their symptoms, at least have a brief escape from that panic or anxiety or depressed mood. Causal effects, and very significant studies out that would look at the impact of marijuana use and the first onset of psychotic episode, and even possible correlation to increased risk for schizophrenia. And then just common or correlated causes. Some of the same environmental or other risk factors that lead to mental illness would also lead to substance abuse. There may be significant overlap there. Same line, what environmental factors do we know contribute to addiction? Stress, ongoing anxiety. I'm going to show you an interesting study here. I think it's on the next slide. Physical and sexual abuse. It's actually one of the most commonly asked questions when you're trying to do a substance use screen, and particularly in women, it greatly elevates their risk of developing a substance disorder. Witness violence. So again, it's these, remember, most of these addictions occur early in life, so we're actually talking about adverse childhood experiences. Beyond peers who use drugs, your peer group actually does matter significantly, and access or availability to drugs. They're a very high risk factor. This study that really identified what is the impact of stress and their likelihood to be drawn toward or use substances. So our pet of two mates. They're both individually housed, so relatively they would have about the same amount of stress in their life. And you can see PET scans look pretty essentially similar. They moved them into different housing, so now they're group housed. Well, one of these monkeys became dominant to essentially have more access to natural rewards, sex, food, etc. One became subordinate, so he was still exposed to, or more exposed in this case perhaps, to things like violence, restriction of food, etc. And so the effect on the dopamine D2 receptors. And you get up on the PET scan. So the monkey that became dominant and meet most of his own needs had a remarkable reduction in stress and utilized less cocaine in relation to the monkey that became subordinate, and his stress remained or actually increased. At least two of those events, or two of those marks, were statistically significant. It is an interesting concept that the stress environment not only changed the receptor environment, but changed the behavior and the drug-seeking behavior of the two primates. Adolescents. This is a study that NIDA does every year. And by the way, I want to take a moment to just thank NIDA. Most of my studies, most of my slides, I will typically look to them first, and they're always only allow us to use their slides, but they have great studies up there. But every NIDA essentially looks at perceived risk versus use in youth or adolescents. And you can see this is from 75 to 2007. It virtually always perfectly correlates that the youth's fear of using a drug, or in this term is perceived risk, always inversely correlates with the past year use. So the greater the fear, you see 91, and I think this particular slide, although it would be true with virtually any drug they're looking at, this is marijuana, I believe. But in 91, the perceived risk went up, use went down. You can see in 77, where perceived risk was very low, use peaked. It only goes up to 2007, and looked in the last few years. One of the things that's concerned me about the youth movement to legalize marijuana is what is adolescents and youth perceived risk. I would assume it is falling, which virtually always correlates with an increase in use, no matter what the drug is. It'd be something for us to monitor. Addicts just quit. With the structure of the brain earlier, we know that in the frontal cortex, control is expressed. It can override drive. Saliency doesn't override control, and memory as a factor is pretty neutral. But in the addicted brain, controlled person probably didn't get an opportunity to develop normally, since most substance use occurs during the developing brain, but saliency and drive effectively override the ability of the individual to express control. And here that might kind of help you to express this. I think a kind of interesting study, but here is a PET scan. It was a study that compared recovering addicts, so they stopped using cocaine and they compared with people who had no history of cocaine use. But this is the same brain. It's of a recovering addict, but on the left, the individual is shown a nature video, so no reminders, no triggers for the idea of substance use. So they showed things like mountains, rivers, animals, flowers, etc. The video, cocaine and drug paraphernalia such as pipes and needles, and you can see this shows is the amygdala lighting up during the cocaine video. This is part of the brain's limbic system. It's critical in memory and emotion evocation. And so craving, which is one of the ways people subjectively express that feeling, triggered very significantly there. And it's exactly responses like this that override the individual's ability to express control. A highly emotional part of the brain that's also connected to memory and drive, and saying, you really want cocaine. So why the statistics on trying to just quit, particularly with opioids, which is the current crisis we're in, is rarely effective. So it's essential, and it has to occur with all the tools that we have. Pharma treatments, medication-assisted treatment. If you look at the statistics on people recovering from opioids, from addiction, I'm not talking about people being able to taper off of opioids and have success, but from someone who's truly addicted without the use of medication-assisted therapy, it's really kind of a dismal percentage for outcome. But therapies, social support and services, and medical services all are significantly important. And we already saw how common behavioral health comorbidity or disorder is. We have to treat all of those issues if we're going to have success. Simonitis principles of treatment. No single treatment is appropriate for individuals. I would agree with that. There are clearly, through research, some areas that are probably less negotiable or less adaptable than others. But just like treating someone for diabetes or tension, the more you can, I think, personalize the treatment to the individual's lifestyle and environment, the more success you'll have. I think we have to become comfortable with is that multiple courses of treatment may be required for success. I'm going to show you a slide here that compares substance use with other chronic medical conditions. But I think it's uncommon. It's not uncommon among psychiatrists or addiction folks either, that if someone's been through treatment, chemical treatment, and had 3 months, 6 months, a year, and fails again, the idea is that they don't need more treatment. They know, or they should know everything they need to be successful, but it's just not an accurate approach to treatment. Just like someone who has their sugars fall out of control in diabetes or has their hypertension spike for several days, it's more redesigning and reworking the treatment plan with the patient than assuming that it's entirely up to them to get it back under control. Using science to develop better treatment and utilizing all the things we've talked about. Some interesting, I think, and kind of exciting developments we may see. So the basic research on the left kind of triggered the idea, and the medications that are coming out of it. You see the amyloid 1 or cannabis 1 knockout mice have a decreased response to multiple drugs of abuse. So we're creating the C1 antagonist. Opiate agonists, we talked about already, methadone, buprenorphine are the two FDA-approved treatments for opioid use. Known as the Smokers who are poor nicotine metabolizers smoke less, so they're working with inhibitors of metabolizing enzymes, and then CRF antagonists, another potential course of action. I think this is one of the things that is clearly changing in treatment of addiction. And if you look at of this year, I believe it was January, American Psychiatric Association put out their new guidelines for treatment of alcohol use disorder. One of the things that's changing in the medical field is the idea that you need to use medication treatment to assist addiction and addiction recovery wherever it's appropriate. And we're getting very close to the line where saying not using appropriate medication therapy falls outside the standard of care. Guidelines don't yet go quite that far, but that is clearly the way the addiction field and the addiction profession is moving. I promise you at least one slide that would compare the rate of addiction with other chronic illnesses. And this is one that is from 2000 in JAMA, a little dated, but does talk about the rates are very similar for drug addiction and other chronic illnesses such as hypertension or type 1 diabetes. Again, part of my argument, part of my hopefully persuasive argument this afternoon is to talk about addiction as a chronic medical condition and a disease of the brain. These are some summary thoughts along those lines. Protracted abstinence and restored functioning, it is a long-term process, and we have to get used to the idea that it may require repeated episodes of treatment, redesigning a treatment plan, reassessing where the patient's at and what their needs are at any given time. This is an illness where one patient's been through treatment, we really expect them to manage all aspects of it on their own through 12-step programs, which are highly successful and beneficial. Really about peer support. That over the next decade, one of the things that we will be more comfortable about is addictions are talked about in the medical community with my primary care, with my endocrinologist, so that we're all aware and all factoring it into our patient treatment plans. Recovery is possible, however. The longer you stay sober, the longer your duration of abstinence after treatment, obviously the better your chances for success. But you can see in the first 1 to 12 months, your rate is dismal. About 36% of those who go through treatment only gain their abstinence about 36% of the time. If you get past the first year, you start to get over that 50% mark, and you have a much better chance of being able to sustain. You can see 5 years plus. This study went out to abstinence of 7. You have a pretty good chance, although not a perfect chance, of remaining abstinent at that point. Years after years, you're in pretty good shape. And hope, although we said there are significant long-term changes to the brain, see here some different cuts from a scan. Normal control here, we have the methamphetamine abuser 1 month after abstinence, and you can see there is still a reduction in dopamine transporter. But at 14 months abstinence, this particular patient is back to looking very similar to the control in terms of DAT activity. Real quick, treatment is incredibly important. Here, the rate of remain drug-free. This is a study, I think it was in Delaware, community treatment plus aftercare. Again, I think the take message is this is not these illnesses. We should expect a high success rate if we expect our patients to do it on their own. That's the end for today. And Mark, I don't know if you have questions.
Yeah, we have time for a couple questions. Any questions for Dr. Stanley? Looks a little quiet. So, Dr. Stanley, if you don't mind, I wouldn't mind asking a couple. The one question I had goes back to looking at your slide about the addiction and how the majority of addictions at that 12 to, I think it was right around age 25 range. So
right.
My question is, so as the likelihood or, what is it, likelihood or the prevalence of becoming addicted to something decreases with age, what happens to the actual addiction itself to a person who, say using an illicit drug or something at a young age, and as they age, does that addiction itself fall off, or does that generally stay consistent? And then the second part to that question is, how does an addiction to something impact the further development or maturing of the brain?
Yeah, both good questions. And if I understood the first part, Mark, there's very rarely spontaneous recovery through aging from addiction, and maybe that's not what you're asking. But the longer you go with that exposure or use or dependence or abuse of a drug, the less likely you are, in the older in your lifespan, the less likely it's going to become a problem for you. I don't know if those answer your question exactly.
Yeah, actually, your first one did about spontaneous recovery. That was exactly what I was curious about. If a person became at an early age, does that addiction have a tendency to cure itself over time? And what I'm hearing you say is no. I mean, generally, once it's established, it's there.
Yeah, I would say it never happens. Yeah, it never happens, but I think it's a pretty rare event. And what is difficult, I think, when we talk about addictions with young people, is if you people kind of wake up one day and say, I've got a substance use problem and I need to quit, it's really some consequence that drives them to treatment. So, if you think of the consequences, they're legal, their health, their filler, their relationships. And that last one, relationships, is probably the driver for most people to seek treatment or to seek wellness, if you will. The thing when you're young, particularly when you're an adolescent, if you're in a family, your parents kind of stick by you, whatever. Relationships have a tendency to come and go. Health, it takes a long time to really endanger your health, and consequences also often kind of be a little ephemeral. So it's sometimes demotivate and get young people into treatment. I want to answer your question about the developing brain. There's really interesting data now, although it's been called into question a little bit, the impact of this on the developing brain. A study out of Dunedin, New Zealand, where they were able to follow a cohort. They were following and continue to follow a cohort age about 12, 13, 14 up. They're now in their late 30s, I think. They showed that those who were regular marijuana users prior to age 18 had a reduction in IQ of about 8 points compared to their cohort who did not smoke regularly prior to age 18, or who began smoking after the age of 18. So it didn't matter if as long as you didn't smoke before 18 or during the most important developmental years, those years it had the greatest impact on later testing of IQ. So the IQ testing on these kids at age 12, were able to repeat it at age 30s, and it actually showed a decline, whereas the other cohort had stayed the same or actually gained a point or two. It's supposed to be relatively stable over lifespan, but it's possible to change a few points. that is, I think it has a very big impact on the developing brain, and it's probably regardless of what drug, but even a drug like marijuana, which many would tell us is relatively harmless to the physiology, appears to have an impact on brain development.
Thank you.
Yeah.
Any other questions for Dr. Stanley? So, hearing none, would it be okay if anybody that's listening to the program today was ready to ask a question, if they forward it to me, if I could go ahead and send that to you?
That'd be
perfect. So if anybody does have a question, feel free to send that to me at meast@esma.org. I want to certainly thank Dr. Stanley for taking his time today and sharing his knowledge with us. I'd like to thank those who are listening in. And I'd also remind you that the next program in this series is going to be on addiction and pregnancy. And the presenter will be Dr. Erica Schipper. The presentation is scheduled for Tuesday, July 17th at 4:30 p.m. And with that, I wish you all a good day.